In this presentation, I'll be talking about the research involving a comparison of the effects of the Mediterranean diet versus the low-fat diet on non-alcoholic fatty liver disease. This evidence analysis project reviews the research regarding the impact of the Mediterranean diet versus the low-fat diet on non-alcoholic fatty liver disease. Ultimately, this review aims to understand if the Mediterranean diet is more effective than a low-fat diet in improving the pathology and symptoms of non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is the most common chronic liver condition in the Western world, currently affecting 38% of the world population and 25% of America's population. Non-alcoholic fatty liver disease is typically caused by metabolic dysfunction and is diagnosed when 5 to 10% of the liver's weight is made up of fat. In the United States, the prevalence of non-alcoholic fatty liver disease has doubled in the past 20 years and now affects 100 million people. These rates are expected to continue increasing in the coming years as more people develop obesity, type 2 diabetes, and metabolic syndrome. Many researchers speculate that the rise in non-alcoholic fatty liver disease prevalence in the United States is largely attributed to the traditional American diet of the present day, which is high in carbohydrates. Non-alcoholic fatty liver disease ranges in severity depending on how long the affected patient has been left untreated. It typically begins with steatosis, or the accumulation of fat in the form of triglycerides in the hepatocytes. Patients in this stage typically experience fatigue, pain in the upper right abdomen, weakness, and jaundice. If left untreated, non-alcoholic fatty liver disease may progress into steatohepatitis, in which hepatocytes enlarge, causing the liver to swell. Patients in this stage may bleed and bruise easily, have itchy skin, jaundice, ascites, loss of appetite, nausea, and edema in the lower extremities. From there, Mallory-Denk bodies may develop, which are eosinophilic, irregularly shaped aggregates in the cytoplasm of hepatocytes. A person may also experience fibrosis, or the development of scar tissue resulting from prolonged swelling. The final stage of non-alcoholic fatty liver disease is cirrhosis and is characterized by a permanently damaged, non-functioning, swollen, and scarred liver. A person suffering from cirrhosis may experience swelling, reduced blood flow to the liver that manifests as high pressure in the portal vein, reduced bile output, reduced waste elimination, spleen enlargement, the accumulation of toxins in the blood, and liver failure. In the worst cases, a patient will need a liver transplant. Risk factors of non-alcoholic fatty liver disease include high visceral fat, type 2 diabetes, dyslipidemia, and metabolic syndrome. Yet, non-alcoholic fatty liver disease is primarily managed through nutrition and lifestyle management without the use of pharmaceuticals. A Mediterranean diet has often been the recommended nutrition intervention for choice for people looking to improve their non-alcoholic fatty liver disease. The liver is directly impacted by nutrition, as its main roles include processing macronutrients and some micronutrients, storing vitamins, and detoxifying harmful substances such as alcohol and pesticides. When dietary carbohydrates are consumed in excess, the body first uses what is needed for energy. Any glucose that exceeds the body's energy needs is stored as glycogen. Once glycogen storage has reached its maximum, the remaining excess glucose is converted into lipids by the liver through de novo lipogenesis. The liver also breaks down fats that are eaten and synthesizes other fat like cholesterol. The liver produces bile to help break down and absorb fats, and waste products and toxins are removed through bile. When too much dietary fat is consumed, the liver stores excess fat, contributing to non-alcoholic fatty liver disease. However, fat has also been shown to have a healing effect on the liver, as certain types of dietary fats, particularly unsaturated fats, can help improve insulin sensitivity and inflammation, preventing the liver from storing too much glucose as fat. In a multi-center prospective randomized trial conducted in Spain, researchers assessed the effect of adherence to a Mediterranean diet on non-alcoholic fatty liver disease in metabolic syndrome patients. Patients underwent lifestyle intervention, including personalized nutritional counseling and physical activity instruction, with the intention to prevent and treat non-alcoholic fatty liver disease. Patients with metabolic syndrome who had high adherence to the Mediterranean diet displayed dissolution of intrahepatic fat contents. This study has many strengths, one of which is its patient population, which was larger than most other studies conducted on this subject. However, it utilized the food frequency questionnaire to assess the amount of different food groups consumed by participants. Food frequency questionnaires often elicit overestimated intakes of healthy food groups by participants, which poses a limitation to the study as it is likely that participants did not consume the amount stated. However, researchers still observed a decrease in intrahepatic fat content among participants adhered to the Mediterranean diet as described on their FFQs. Thus, this research suggests that a greater adherence to a Mediterranean diet may help to reverse non-alcoholic fatty liver disease and improve metabolic dysfunction. The highlights of the Mediterranean diet include being rich in fiber and unsaturated fatty acids. Additionally, research has shown that higher levels of pentadecanoic acid in the blood correlate with a lower risk for non-alcoholic fatty liver disease. Pentadecanoic acid is a saturated fatty acid found primarily in dairy and fish. In a double-blinded, parallel design randomized controlled trial, 88 Chinese females with non-alcoholic fatty liver disease were randomly assigned to one of the three groups for 12 weeks. One was the Mediterranean-like diet with pentadecanoic acid supplementation. The second was the Mediterranean-like diet without pentadecanoic acid supplementation, and the control group was the habitual diet with no pentadecanoic acid supplementation. Body fat percentage, intrahepatic lipid content, muscle and abdominal fat, liver enzymes, cardiometabolic risk factors, and gut microbiome were assessed at time 0 and following the 12-week intervention. The researchers found that both Mediterranean-like diet groups experienced significantly greater reductions in body fat, liver fat, total cholesterol, gamma-glutamyl transferase, and triglyceride concentrations compared with the control group. The group that received the Mediterranean-like diet with pentadecanoic acid supplementation displayed reduced LDL cholesterol and an improved gut microflora environment. Fat mass, visceral adipose tissue, subcutaneous abdominal adipose tissue, insulin, glycated hemoglobin, and blood pressure decreased significantly in all groups, in addition to weight loss. Thus, the researchers concluded that a diet high in fiber and unsaturated fatty acids helps to improve non-alcoholic fatty liver disease, and that pentadecanoic acid supplementation helps to lower cholesterol and improve gut microflora. In an 18-month weight loss trial, 278 patients with obesity and dyslipidemia were randomized to a low-fat diet or a low-carb Mediterranean diet, with or without moderate exercise. At time 0, 6 months, and 8 months, hepatic fat content and abdominal fat were measured. The researchers found that weight, hepatic fat content, and visceral adipose tissue all decreased synchronously. Hepatic fat content decreased to a similar degree among all groups undergoing regular physical activity. However, the low-carbohydrate Mediterranean diet group experienced a greater decrease in hepatic fat content than the group on the low-fat diet. This study's strengths include the control of visceral adipose tissue reductions when assessing hepatic fat content and weight loss in order to specifically focus on the effect of diet on non-alcoholic fatty liver disease. Additionally, the researchers followed a large group of subjects for 18 months, which is relatively longer than most studies involving non-alcoholic fatty liver disease, thus increasing the validity, reliability, and generalizability of this study. Ultimately, the researchers concluded that weight loss due to dietary and lifestyle changes leads to decreased hepatic fat content, and that the low-carb Mediterranean diet is more successful at achieving these results than the low-fat diet. In this study, the researchers followed 297 participants from 2 pre-dimed plus centers receiving the Mediterranean diet. After 1 year of the intervention, participants were organized into 3 groups based on the degree of their non-alcoholic fatty liver disease post-intervention. Group T1 displayed the most improved cases of non-alcoholic fatty liver disease, and Group T3 displayed the least improved cases, all of which were analyzed by liver imaging and function tests. Next, the researchers analyzed the gut microflora of all participants to see if there was a correlation between a specific gut microflora environment and improvement in non-alcoholic fatty liver disease. Participants deemed non-suspected liver fibrosis showed higher abundances of certain gut bacteria compared to those deemed suspected fibrosis. Thus, the researchers concluded that gut microflora changes induced by the Mediterranean diet lead to improvement in non-alcoholic fatty liver disease. In conclusion, ample research evidence shows that the adherence to a Mediterranean diet leads to greater improvement in non-alcoholic fatty liver disease than a low-fat diet. It is hypothesized that these results are typically seen due to the low carbohydrate nature of the Mediterranean diet, which helps to clear and prevent fat accumulation in the liver by 2 main mechanisms. First, a low carbohydrate diet leads to lower insulin levels in the body. Insulin signals for the liver to store excess carbohydrates as glycogen and fat. Thus, with less insulin in the body, liver fat accumulation is decreased. Second, low insulin levels associated with decreased carbohydrate intake put the body in a state of ketosis, in which stored fat is catabolized for energy, since the body cannot obtain sufficient energy from glucose. As a result, the body may start catabolizing the accumulated fat on the liver for energy. Thus, carbohydrate restriction depletes the body's glycogen stores, causing it to break down stored liver fat for energy and heal non-alcoholic fatty liver disease. However, this phenomenon varies based on a person's genetics, severity of non-alcoholic fatty liver disease, diet quality, and nutrition status. There is a need for further research on the best diet for treating non-alcoholic fatty liver disease because an excess in both carbohydrates and fat have been shown to lead to the development of non-alcoholic fatty liver disease. It is difficult to limit both carbohydrates and fats in any person's diet, as these are essential macronutrients. Thus, further research is needed to determine which diet is more effective in treating non-alcoholic fatty liver disease. Rates of non-alcoholic fatty liver disease are rising among children and adolescents, which can largely be attributed to increasing prevalence of obesity and metabolic diseases in this age group. However, non-alcoholic fatty liver disease used to be rare among this population, and as a result, there is limited research focused on non-alcoholic fatty liver disease in children and adolescents. Additionally, non-alcoholic fatty liver disease is common among people suffering from eating disorders, such as anorexia nervosa and binge eating disorder, yet there is very limited research on this population. Both of these populations would benefit from primary research, as there is not enough published research currently to formulate an effective and convincing research review.